Okay, so today we're going to describe the origins of our profession, some of the changes in the profession that developed at the birth of the modern era, and recognize historical events that has led to why national health coverage has not come to pass in the U.S., despite repetitive efforts. Hopefully bring that knowledge forward and recognize why the U.S. linked employment with health insurance versus European nations. And by the way, maybe before the next session, I'll update some slides about current status. Um, so initially back in the 1800s, colonial days, medical education consisted of 2 years at most of what would be considered a college at the time, learning Latin and perhaps ancient Greek philosophy. The practice of medicine was apprentice-based, and it was anecdotal. Back in the first part of the 18th century, and actually even into the 19th century, first part of the 19th century into the 20th century, doctors struggled financially. They held little status, and they competed for patients and revenue. The profession was not organized. It was ineffectual in improving standards of care or improving how patients did with their ministrations. Certainly, practice and education was not standardized, and there was very little privilege as in terms of status of physicians, in part because in a more agrarian society, there was a lot of self-reliance. Family experience as well as Native American experiences with home remedies often trumped what the physician or the physic of the time could do, as did common sense. So remember, doctors figured out early on how to change homeostasis. We could screw up a biological system by purging, by phlebotomy, inducing dehydration with vomiting and diarrhea. We can give poisons. We could provide leeches. But they weren't, although a patient may be impressed about how sick they could get from our ministrations, they weren't impressed about how well they might get. So the home-based remedies obviously took precedent, and hospitals of the time were charity-based, often church-associated, and they housed the destitute, chronically ill, homeless, or insane. They were not places of first resort, they were places of last resort. And again, by modern standards, unsanitary before the era of germ theory. So here's Benjamin Rush, who was one of the signers of the Declaration, and his tools for phlebotomy. Here are some of these magic oils for killing pain. Some of those may have contained opiates, which would have been good because they would have worked, but often they did not. So what kind of insurance existed prior to our modern age? Well, there wasn't much need for medical insurance, right? There wasn't much medical care that was appropriate, but there was a need for disability insurance. So if you were a worker and you were injured on the job, you could not bring in an income, your family could starve. So in Europe, over many centuries, guilds had developed called sickness funds. These were common in Germany, also common in Britain and other nations. And Britain called them friendly societies, the sickness funds in Germany, and they basically supported widows or a family after an injury or death. And they served as a familiar framework by which to cover care in a later century, those sickness funds. The U.S. did have some benevolent societies. They tended not to be quite as common, and for a variety of reasons, just perhaps because of our agrarian settings or the like. And one thing that was popular in terms of insurance was accident insurance. It was first offered in the United States in 1850, and one thing that became very popular was funeral insurance. So if you died and you had no income, how would you bury yourself? Or how would you be buried? These European sickness funds, again, were the major bulwark of how nationalized health insurances came to be popular in those countries, and it was the structure that was used for that. Again, insurance had a limited basis. The scientific method, of course, changed everything with cell and germ theory, aseptic technique, anesthesia developed mid-century. Here's William Morton for using anesthetics in 1846. Instituted by the mid-1800s and certainly late 1800s. And these scientific advances, both in medicine and surgery, led to necessary expansions of education. The nature of medical education all of a sudden was very different. Here's just stuff that you already know. You have Semmelweis, who was a pioneer with aseptic technique, Pasteur and Koch, who developed the germ theory, Joseph Lister, etc. So this was all happening mostly in Europe, and a European model came to be embraced by United States forefront medical schools. And they started to introduce what you are all familiar with, your bioscience courses, anatomy, pathology, clinical training, as well as affiliating a medical school with the sciences that were university-based. So training expanded from 2 to 3 years. The academic year expanded from 4 months to 9 months. So that was the nature of education. In 1893, Johns Hopkins, one of the first medical schools to embrace a European model, started a residency program. Medicine is now becoming a complex endeavor. And with it came a rise of professional sovereignty or respect, or carving out a place in society that physicians had not taken previously. So one of the ways that also happened was with hospitals. As we mentioned, hospitals were previously sick houses for the incurably ill, and they became a model of modern care and a model of modern architecture of the 1800s. They were citadels of antiseptic surgery and professionalism. People started to look at hospitals a little bit differently. They were a place that one could get well rather than just die or be incarcerated. So at the time, initially, there were many charity and public hospitals, but private hospitals were set aside for the elite. So in Philadelphia, where I did much of my training, Pennsylvania Hospital was the elite setting in the midst of downtown. Philadelphia General Hospital served most of the populace. In Boston, Mass General Hospital served the elite. Boston City Hospital served everyone else. And of course, in that age, out-of-pocket payment was really the only means of paying for medical care. And even in the elite hospitals, there were two classes of patients. The poor exchanged their bodies for training and teaching in exchange for medical care. And the rich received, the private rooms rather than the large wards and the porcelain plates. So that's a picture of Pennsylvania Hospital, and this is a picture from Philadelphia Hospital from the wards. Certainly during this time, folks started to view hospitals, no matter what your class, in a different fashion. So in terms of education, by 1900, again, many medical schools were still two-year programs. There's a lot of discrepancies in terms of education. They're run by local hospitals for profit in many instances, and science had not necessarily caught up in many medical schools. The American Medical Association, we're going to talk about them in a future slide, had actually established in the mid-1800s, but it did recognize the necessity to reorganize and protect the interest of its white physicians, of some people in its professional ranks. And so it linked with academics to create a assessment of medical education, which was released as a Flexner Report in 1910. And this report attacked deficits in quality and content of medical education with an effort to standardize the prerequisites of basic sciences, the scientific curriculum, whether it be histology or whatnot, and strengthen state regulation of medical licensing. And as a consequence, it did result in closure of many medical schools. This was put forward by the Carnegie Foundation. In doing so, in standardizing and ultimately improving education, it actually improved care. And as such, it gained power in post-industrial America and assumed complete control of medical education and state licensing laws, as well as state boards. So associated with this, medicine grew its legitimacy and continued to gain prestige and authority. I should spend a moment, since June 19th is tomorrow, talking about racism and the American Medical Association. Again, the history is quite dramatic. Some of its first members talked of essentially ways to justify slave owning. There's a Samuel Cartwright who invented a variety of different illnesses, such as drapetomia, which meant that a person would run away and be sulky and dissatisfied. So they should be whipped strictly as a therapeutic early intervention, and a variety of other bizarre concepts. Many of you may have heard of Sims, who is the founder of U.S. Gynecology. He actually served as a president of the AMA. And he performed experimental surgery on vaginal and colovaginal fistulas and rectal fistulas that occurred often in underage women who were trying to deliver babies. These were often enslaved girls or women who actually served as domestics or were forced to serve as nurses in his clinics. They did not receive anesthesia. There were generally held popular beliefs with no scientific evidence that Black women were impervious to pain. So the role of anesthetics was not felt to be necessary. And the AMA, as mentioned, formed in the mid-century in Philadelphia, but it deferred again at a time just before the Civil War, when the northern states opposed the slavery of the southern states. The AMA, in its diplomacy, allowed individual state societies to determine acceptance of Black physicians. As an alternative, the National Medical Society, which was a society of Black physicians, African American physicians, was excluded from the AMA, the National Medical Association, basically founded as a national association not too long thereafter. Resulting from the Flexner Report, there were a number of Black medical schools that did close, which further limited the access of citizens to African American peers as physicians. They were also excluded from AMA-associated medical societies. And at that age and thereafter, that was the only means for medical licensure and hospital privileges. It's a history that, as we'll see, was not unique to the turn of that century. But in any case, post-industrial medicine, now we're talking the early 1900s, in general, improved medical care. It advocated for uniform licensing and coordinated education and training. And we'll see that it did accept one concept for a national health insurance early on, but thereafter it was organized purely to defend doctors' independence from the needs of industry or from government concepts of nationalized health insurance. So whenever efforts to create a health insurance arose, the AMA has a long-standing history of doing such opposition. It did not want any government intrusion into healthcare coverage. It wanted physicians to continue to have a fee-for-service reimbursement method. So just as a summary, initial ineffectuality and absent cultural acceptance, in an agrarian nation resulted in limited legitimacy early on. The scientific method and organization of the profession allowed a rise in legitimacy. The AMA was assumed an exclusive role in improving care and standardizing care, but also was consistent in preventing intrusions into the business of medicine. And this was an age when disability and medical insurance was not yet necessary because it didn't play enough of a role in people's day-to-day life to be important. So this is a photo of a typical sweatshop of the industrial age. And so disability resulting from black lung, from pollution, from pneumonia, from loss of a limb in a moving part, all that was part of the reality. Again, these sickness funds had been easily adopted in Germany to receive actually federal funding towards disability insurance. The other thing happening in Europe in the late 1800s, unlike in the United States, was a wide dissemination of Marxist philosophy, which carried a different connotation. It was brand new. It was a different approach to thinking about economic distributions and the like. The other thing in Europe that was unlike the United States was there was a great degree of labor unrest. And as a consequence of Marxism, there were socialist parties that arose in Germany and England that led opposition conservative parties. Remember, the U.S. had a republic, a democracy. Many of the European nations had parliaments, but they still had very powerful monarchies. When it came to Bismarck, a powerful conservative leader. Folks like Bismarck looked at labor unrest and the strikes and the potential loss of his political power and wanted to assuage the populace with the benefits that were being demanded. So here's a typical strike of that age that was convulsing the German society. So they made national health insurance as a response. He would confront political defeat otherwise to the Socialist Party. So he created a public sickness coverage for the working class. It was compulsory, and it was basically a disability and a sickness insurance. The coverage of medical care was included, but again, it was a small aspect of things. It was jointly funded by both the employer as well as the worker via their guilds. And again, paid sick leave and unrestricted medical care. Very quickly, Sweden, Denmark, France, Austria, Hungary, Norway, Russia, and the Netherlands followed. So this was a wave that was occurring across the puddle. Britain in 1911, under Lloyd George, also created a National Insurance Act. That was a forerunner of the national health programs in Britain. Again, funded by the employer in part, by the wage earner, as well as government. And it offered unemployment support and local administration, which is also important. So it was if you had a benefit society, they would be widely involved in the administration. So this progressive era of social activism and political reform occurred across the world, and America was not immune to that. American women still did not have the right to vote, so suffrage was a major issue during that time. The other elements going on in the United States was the recognition of unsanitary practices in meatpacking industries and food, and the horrors of industrial workers' environments. Muckraking journalists like Upton Sinclair, who wrote The Jungle, which is specific to the meatpacking industry, really brought this home to an American public. Patent medicines were totally unregulated. Some of them had coca in them or had opiates in them. So many of them were worthless, which is the case today, but they're also tainted with lead or other heavy metals, and really not too healthy for the public. So one of the first, Teddy Roosevelt, by the way, was progressive in his own right. He was the trust buster. He brought down the Gilded Age, where the railroad barons had basically commanded incredible wealth and power in the distribution of railroads and goods across the United States. So he broke those railroad trusts and some other trusts. As part of his actions, he also created the precursor to the Food and Drug Administration, known as with a Pure Food and Drugs Act in 1906. For the first time, they were looking at these patent medicines, these over-the-counter medicines, and starting to make sure that they did not have poison in them. His bill in 1912, again, this was before World War I, his party did call for health insurance for working class, which was a compulsory insurance. That met with opposition, as you might imagine. And the opposition was not entirely from um, folks in the insurance industry, because the insurance industry was relatively weak and small. Some of the opposition was basically due to the same folks who opposed this party for its politics and breaking up wealth. Um, During this progressive era, the Department of Labor was created and with occupational safety, wage and hour standards, unemployment benefits. And the only time that the American Medical Association ever supported any kind of national insurance was between 1905 and 1915. And there was a smaller union, the AAL, that had proposed providing coverage to the working class or folks with limited income, that would provide coverage for doctors, nurses, maternity, hospital services, sick pay, as well as funeral expenses. And their mistake was they decided to cover funeral expenses because then the insurance industry, which was doing a lot of that, really opposed this dramatically. And what was also happening around this time was Bolshevism. 1917, the Bolsheviks took over power in Russia. There was anti-German sentiment that was developing just before the war with Germany. So there were other forces at play. But we did see after World War I, the Veterans Administration's origins to consolidate and coordinate government activities affecting those injured in the war. So this was a time of international change, but not such change in many ways in the United States. And at least in some of the readings you might see from Starr, he writes that in the United States, we had little labor problems. Instability in labor was less of an issue. We actually saw a rising middle class, and there was not the same degree of political unrest. The major the major labor union in the United States was not the AAL, but the American Federation of Labor, or the AFL. And unions were starting to influence the benefits that their workers could get. And if you could offer some kind of disability insurance to your worker, you don't want somebody to assume that role because that's where your power lay with providing improved benefits to your workers. That's why you would vote for a union. So they opposed any consideration of national health insurances. Again, we talked about the Red Scare with Bolshevism, distrust of this concept of socialism, and anti-German sentiment. And really, come 1920s, the AMA has consistently opposed any kind of interference in the financial interaction and medical care by state or federal government. So again, you may have the chief business of the American people is business. They're profoundly concerned with producing, buying, selling, investing, and prospering in the world. That's Calvin Coolidge in 1925, a few years before the Great Depression. And so what was there a crying need for? In America, there was a crying need for disability insurance. Again, that was the major cause of lost wages, and it wasn't medical coverage or medical care that needed coverage. Here's a fellow who had lost an arm, a very common phenomenon. It's titled One Arm and Four Children, which is a reality in terms of you had potentially your family could starve or become destitute if you could no longer work. So disability insurance became very popular. And around 1911, during this progressive age, workers' compensation came to be. So this was provided in part by state, in part by employer and employee to cover lost wages. The insurance companies really were uninterested in determining premiums, and we're going to talk a little bit about this. So the early insurance companies did not have any actuarial experience. They could not predict what percentage of the people that they're covering were going to need to be funded for medical, for either workers' compensation or lost wages. So they really did not undertake that. They were still doing funeral insurances and other less other issues. But one thing that did start to develop as medical needs became more prominent was something called indemnity health insurance. So in the 1920s, we first start to see an increased need for typically surgical services, but also diphtheria toxin was being provided. There's a variety of other medical interventions. So there's new care and new costs. Insulin was discovered in 1921 in Canada. Fleming discovered penicillin, surgical techniques, X-ray techniques advanced. Sulfa antibiotics actually were first being developed. So as these hospital and surgical care advances ensued, treatment became more pervasive, more a part of people's day-to-day life, and more expensive. Still, by the mid-1920s, people paid out of pocket for their medical care. But it was no longer, people were no longer able to predict what their future costs might be for that medical care. If your daughter got appendicitis, that could set you back a decade. So now you could cure these surgical issues, but the coverage did not exist. So it's around this time that insurance companies started to figure out how to provide medical coverage. And so basically, if you as an individual can't predict the likelihood of your becoming sick, you're not going to also know the likelihood of how much percentage of your income needs to be put aside to save for that hardship. That's what people did. They would put aside a nest egg. But that nest egg you couldn't determine what the size might be. So an insurance company would do what's called risk pooling. It allows shifting the risk of financial loss from the individual to that third party that's offering the insurance. The size of the risk pool, what services would be included or excluded, and the percentage of the premium you're taking in that gets sent back out to cover medical care, called the medical loss ratio. All of that contributes to the cost of the premium, the charges that an insurance company would pay for medical coverage. How many of you have heard the term medical loss ratio, just out of curiosity? Okay, there's much to learn. So because that is a term that is really the underpinning of a lot of different types of insurance. This concept, I'll go over it again, that the medical loss ratio means what percentage of the revenue an insurer is taking in from premiums gets lost to actually provide medical care that goes to services, that goes to pay the doctor's salaries, the surgeon's salaries, the antibiotics, etc. Um, how does an insurance company make a huge profit? Well, it wants to limit the medical losses it incurs by restrictions. Those restrictions include excluding conditions that it would cover. It would make a profit by trying to identify which enrollees to go after, to cherry pick, and to try to exclude via a variety of mechanisms those lemons who will cost them too much in terms of profit. And so that's the nature of insurance. Now, it doesn't have to be for profit, as we'll see. And one of the ways to keep there are many ways to keep down costs, and limiting profit is certainly with other mechanisms is one way. But the point is well taken that if the premium is less expensive by making these exclusions, the cost of the premium will also be lower for applicants. So indemnity insurance, again, you don't see it very often, if at all, anymore in the United States, is when an insurer will provide direct reimbursement to the enrollee. If you're paying a premium on a monthly basis or a yearly basis to Metropolitan Life, I go see the doctor gives me a bill, I send the bill to the insurance company, they directly reimburse that physician for those expenses. And in that setting, the insurer has absolutely no responsibility for the quality of care. They basically don't care. These are the bills that we'll pay if it happens to not be excluded. The liability of the insurance for financial risk includes excluding services for pre-existing conditions. That might sound familiar to you. Setting fixed limits on reimbursement for a specific service, such as in the modern age, physical therapy only 6 times, or 2 weeks of rehab, or etc. And also capping the overall cost of the outlays. So that's how the insurer is able to limit its medical loss. And the ideology of such an indemnity insurance or similar insurance is that you're paying for what you feel you need. If you don't have a family, you're not a woman who's going to need maternity care, we won't cover that. That's excluded. Caps on payments, exclusions, pre-existing clauses all allow an individual who just wants care for, surgeries or for the unseen to an extent, it allows those premiums to be affordable. Those same insurances, however, will often not cover catastrophic financial injuries or illness. There are limits, which is a problem, of course, with such insurance. So insurers learn to estimate risk to maintain profitability. And these are some other terms, and you'll find this in the Reinhardt book. There, how many of you have ever taken out or are familiar with medical underwriting? Is that a term known to you? That a little bit, right? So basically, a health insurance premium, how much I pay to not have to pay for care down the line for medical care. That premium is based on an individual's health status. The insurance companies learned how to predict based on age, certainly, occupation in terms of environmental risks, what part of town you might live in, but also if they took a family history, other issues. Again, as science progressed, whether you had hypertension, whether you had diabetes, whether you had a history of asthma, etc. So the health insurance premium was based on the individual status of the health of that individual. Those who had more medical problems or higher risks paid higher premiums. And they also could deny providing care if somebody had too high a risk that wouldn't be profitable for them. So they wouldn't provide health coverage. That is different than a community rated premium. So community rated premiums is when you have a very large pool, an entire town of 10,000 people or better, 100,000 people. You've got a large risk pool. So within that, you have some chronically healthy people. I'm sorry, within that risk pool, you have some chronically sick people, but most people are healthy. The majority of the enrollees will not incur medical costs. So the well people subsidize the sicker members. That is the basis of Blue Cross Blue Shield that we'll talk about shortly, as well as Medicare and the Affordable Care Act. So that's called community rated premiums. So going forward, with a little diversion on any questions, folks mystified about what we've just touched on? It's going to come up again. We've seen Calvin Coolidge, what they call it, the swinging, well, the something 20s. What's the word I'm looking for?
Roaring 20s.
Roaring 20s. Thank you. That gives way to the stock market crash of 29 and the Great Depression. We now had an American society in which there was generalized insecurity, financial strife, 25% unemployment, and covering people's day-to-day ability to purchase food and survive via unemployment insurance. And if one is elderly and no longer working, old age pensions, just being able to survive to afford the roof over your heads and feeding your family, that took precedent over the efforts to institute a national health insurance. FDR's, and again, you could find this and read this in more detail in a variety of sources. But the New Deal initially did have some elements of a national health insurance because it was felt to jeopardize the potential to pass Social Security and unemployment insurance as on a federal basis. It was jettisoned. It was felt to be too risky. By 1929 and the Great Depression, healthcare again was only 1% of GNP. Hospital costs were rising, but unemployment was key. Just to mention this compulsory national health care program that failed to get traction in 1934, 1938 was called the Wagner Bill. That was strongly opposed by, even in the midst of the Great Depression, by the American Association and hospitals. One of the things that was happening during the Great Depression is physicians were having a trouble making an income as well. Patients who may have gone to the doctor's office for their sore throat or for a boil couldn't afford it anymore. They weren't coming in to be seen. But the AMA in it was still firmly against any national intrusions into health coverage. But one thing that they did accept was Blue Cross Blue Shield. So let's touch on that for a minute. So the birth of the blues, I think one of you was at Tulane and maybe associated with Baylor Hospital, Baylor University Hospital. So in 1929, the hospital, Baylor Hospital, had, like many other hospitals, tons of empty beds. Nobody was coming in for their elective hernia repairs. People couldn't afford it. But people still had periodic medical necessities. So he came up with a concept for particular professionals, nurses and teachers within Dallas, to pay 50 cents a month to receive up to 21 days of hospital care per year. If you have a large enough pool of nurses and teachers, you can make that happen. That, again, costs were a lot smaller during the Great Depression. There was not much inflation. Of interest, there was no limits on how the hospital would determine those costs, but you could be sure they're trying to fill those beds, so they're going to be self-declared costs that would be affordable during that era. So in 1936, what had started in Dallas as a small program was being expanded across the country. And it formed the first nonprofit prepaid insurance for hospital care, now covering 1,500 school teachers and very rapidly disseminated across the nation. By the 1950s, it increased from 6 million people in 1940 to 78 million people. I'm sorry, that's wrong. But by 1950, it had already, by 1940, it had gone to 6 million people. I guess what I'm trying to say is during the 1950s, it expanded wildly, such that I was covered as a child. My family was covered into the 50s, 60s, and 70s. That there was 80 million people in 1971 who had Blue Cross Blue Shield. It was the most prevalent form of insurance. It was nonprofit and community rated, and it had community boards as a nonprofit. Blue Cross Blue Shield actually had input from community members, from business leaders, from hospital leaders, and it was run with local control of interest, even though it was a national organization. And that's something that people don't recall these days. There was an indemnity insurer, which was called Prudential Health. That was the largest insurer. other than Blue Cross Blue Shield, and that covered about 50 million lives in 1971. Many unions would use Blue Cross Blue Shield. Many people were covered through that. So by 1939, actually, Blue Cross, which was just hospitalization, was expanded to include Blue Shield, which covered physician fees. And again, that widely expanded. And again, there were a number of other nonprofit cooperatives and prepaid or capitated. We heard that term yesterday. Capitated means the physician would be paid by the insurance company a certain amount per month for their employees. Unions during the 1930s were also growing in power, but the nonprofit community-rated Blue Cross Blue Shield insurances were not fought by the AMA. They were acceded to because doctors also needed to make an income, and this would help folks come in for care. The late 1930s, and actually mid-1930s, there was the WW Works programs. You had in the insurance industry millions of unemployed, typically young men, employed by the government to build dams, whether it be the Grand Coulee Dam, or in New Hampshire, where I reside, you had people taking down forests for lumbering, employing people who would otherwise be unemployed. They weren't building dams out this way. They were doing lumbering with labor camps and a variety of other camps to keep people employed. So you now had millions of folks who you might say, well, they could be covered by a federal insurance, but it was opposed even at that juncture. How to cover the medical needs of a working population. This is actually the origins of the Health Maintenance Organization. How many of you have heard the term Health Maintenance Organization? Yeah, most of you. So that term actually was not applied till the mid-1970s. But what it refers to is a prepaid plan that I'll describe in further detail here, a capitated plan. So Kaiser Industry created coverage for its shipyard workers and its steel workers and its major project dam workers by hiring its own physicians. It not only provided capitation to a physician, but it actually hired the physicians. They worked for Kaiser Industry. The physicians worked out of clinics built by the industry on site. So if you're working in a steel yard in Oakland, California, and you suffer a serious burn, you'll go to the clinic there. Or if you have a more serious laceration, you'll go to the clinic there. If you have a pneumonia, you won't necessarily go to that clinic. You'll go to a hospital, to a Kaiser-owned hospital. They own the hospitals, they constructed the hospitals, they built the clinics at the site of care, and with time, they developed a health maintenance program. Initially, it was to the employees in the early 1930s. They found very rapidly that's not satisfactory to your employee. You need to cover their family as well. So it was rapidly expanded to also cover the children and the spouses of your employees. And in fact, the origins of family medicine comes from the Kaiser experiment with how to cover an individual worker. They were very innovative. And they realized that they needed to provide family care. They also realized that there was a lot of preventative care that they could provide to limit loss of their workers in terms of their hours working, but also the medical expenditures. So we talked about this briefly with capitation is a payment arrangement for a healthcare service provider. There's a term that I use reluctantly for a doctor. It pays a set amount for each enrolled person assigned to that clinician per period of time, whether or not the person seeks care. The amount of remuneration is not based on that worker's health status. But the amount of payment, the capitation, is based on the average expected utilization of care for the overall population of patients. It does vary based on age, and in some instances, health status, if someone might be a smoker, for instance, or something of that effect, or if someone's in a high-risk occupation. If they're climbing up on those steel rigs on the top of a dam, they may be calculated in a different fashion in terms of capitation. But for the most part, it was not medical underwriting. And again, they were called direct service plans. They actually developed the first what's called a staff model health maintenance organization. So a staff model is, as it sounds, it's a clinician group that's integrated into the same organization that provides insurance for its subscribers. The HMO is directly responsible in that setting for the quality of the care and the quality of the services, and it controls financial risk by regulating how many facilities and equipment are used and by having some limitations on expenditures. And it's not going to certainly cover plastic surgery. It will cover essentials, but it might not cover bells and whistles. And the other important component is the HMO will limit its enrollees to care only from the group that it works with, that it's hired. So this prepayment works. It was felt to work best and satisfy its enrollees best when it provided comprehensive primary care. So some of the hallmarks of a staff model HMO is just that: comprehensive, inclusive primary care and preventative care. The goal being reducing costs by treating at an earlier stage of illness. So in contrast to the previous ideology of you pay for only what you might need, the ideology of a staff model HMO is prevention, comprehensive care with limitations of costs via the point of treatment, via the group, the medical group. This changed. I mean, many of you may be familiar with the term HMO in your lifetimes, but its origins were very different. The ideology changed after deregulation. During the 1990s, nationwide, interstate, for-profit HMOs, no longer community-based, would start to, and the most important issue is they were profit-oriented. They're traded on Wall Street. They would make their profit with the same techniques we mentioned just now, but using heavy-handed utilization review. And they would exclude pre-existing conditions. The interest in long-term preventative measures was lost because your patient may change to a different insurer next year. Why would I bother to make sure that you're getting all the preventative measures? That was a problem in the 1990s. Utilization review, prior authorization, these are terms you've heard, those continue to the current age. But fortunately, some of the other measures of limiting pre-existing conditions and long-term preventative measures, those have improved to an extent. So that's the precursor to a modern age. It's already 10:20. Geez, I'm really behind. Uh, do folks need a break? Consensus? We're good? Okay. Do avail yourself if so needed. Let's move on. All right. Part of this talk is how we came to link American insurance for the majority of non-Medicare population with the employer. So that's what we're going to tackle here. Now we have the end of the Great Depression and a wartime economy. Pearl Harbor, World War II ensues. Now, there were some corporations, as we mentioned, with the precursors of direct care or HMOs that had a link between employment and health insurance. But by the way, Kaiser was the exception. There weren't a lot of companies that were doing that prior to 1942. So all of a sudden, you have a national government that is ramping industry to create ships, tanks, airplanes. The government is pumping tons of money into these industries to fight fascism and a global war. American men are being sent into the military. The people who remain are not as plentiful. So workers actually are going to be pretty well paid because there aren't quite enough of them. If you're a company building tanks and you are still making a profit by building tanks, you want to find workers to build those tanks. You're going to pay them well enough to be able to recruit them and not have them work making embroidery for patches for a uniform or making the Jeeps down the road. You want to compete for workers. And so those workers are well paid, but now you have a wartime economy where goods are scarce. All of a sudden, people have good incomes. The depression's over. What am I going to spend it on? All of a sudden, Rosie the Riveter's, she's bringing home the bucks. This is nice. But she can't find the nylons if she wants to go out on Saturday night. There's a lot of unspent salary. So to soak up this unspent salary, there are new taxes that were created on the middle class. You may not be aware of this, but middle class never paid taxes until World War II. The rich did, the very wealthy did. But this is the first origins of actual taxes for the middle class. So it's automatically deducted from payroll. Again, here are folks, here's an older man who's not in the military and other folks who may be there. Did taxes work? No. They implemented war bonds. So there's this promotion of war bonds to take your excess salary, put it into savings. You'll make more savings, and you'll be able to take that out after the war is over and things are rosy. These measures were not sufficient. American economists had remembered what happened in Germany after World War I. Under the Weimar Republic in Germany, people were walking around with wheelbarrows full of worthless marks. Inflation had been rampant. This had been seen in a variety of societies. So there was a great fear of inflation during the war years. So it befell the government to have to do wage stabilization. This Wage Stabilization Act essentially fixed how much a particular industry could pay a worker. They were falling over each other to try to pay more to be able to recruit their workers to their industries. But that had to stop. So this national act limited wages, but what was not limited were benefits. So if you are making those tanks and you're trying to compete for workers for those folks who are making the Jeeps, you can offer health care, which was also now tax deductible for that employer. So that corporation could deduct a health care benefit and offer that as a perk to attract workers. There may be other perks that were there as well. So unions were in favor of that as well. Unions were not happy that their employees could not increase income, but they could increase benefits. That tool did lick inflation. So that was a useful measure that prevented runaway inflation in the United States. But that linkage, that's the origins of linking the employer with and large corporations with health insurance. Again, the Kaiser experience was a small drop in the bucket of most people's health care coverage. War ends. You've got 10 million soldiers returning home. All of a sudden, you've got a high risk for inflation once again. You've got the wartime wages were eliminated. Price controls were eliminated. Labor was demanding new contracts. They were previously working under these wage controls. And these were wartime perks. These health benefits were limited to the period of the war. They were repealed, they were no longer extended. So employers lost the tax deduction for contributions for health benefits. And strikes actually convulsed our country at that time. So throughout it was United Steel, the auto workers throughout the country. Here, there's a sign up there. We called it a work holiday. This is an Oakland general strike in 1946. Basically, the nation was having to contend with huge amounts of strikes. I'm going to take, I didn't know where to fit this in, so this is a diversion on the sad history of the AMA and racism and segregation. But since this sort of fit and chronologically, one thing I should mention, again, there was lots of segregation and discrimination of soldiers during the war. This was still America of the 1940s. But the National Medical Association was trying once again to have its members become its members being able to gain entry to the American Medical Association. It was not adopted. What was happening again with all these issues were some reforms. So do folks know what killed FDR, by the way? Anybody aware of any guesses? Anybody know what FDR died of?
I know he had polio, correct? Is that what killed him?
No, that's interesting. No, he did have polio. And it's so interesting because you never saw photos of the age showing him in a wheelchair. He was always in an upright position behind a podium. He did not die of lung disease or complications from polio. He had uncontrolled hypertension. He had high blood pressure. And in an age where we had nothing to treat it with, thiazide diuretics hadn't been invented. They were maybe just on the forefront of medical care. He died of an intracerebral hemorrhage with his blood pressures in the 230s range over 140. So we take for granted the president of the United States could not access adequate care. So he dies, and Harry Truman takes over. And Harry Truman was one of the strongest advocates for a national health program. In 1946, the end of the war occurs. You've got all these folks home, the family, the economy is potentially booming when not crippled by a strike. There was a bill for the Hill-Burton Act. This is basically doing constructions for hospitals. It was critical. We did not have enough hospitals. The Great Depression was over. Now people were able to spend money on healthcare, medical science, and surgery from World War II had advanced even further. And so the Hill-Burton Act to create for federal funding for hospitals was created. The goal that Truman had was that there be a national health insurance, but he wasn't that interested about integration. So the Hill-Burton Act codified that hospitals in the South could continue to maintain the segregation that they had. It was not a part of the process to address racism in the 1940s. By the way, come 1963, that element of segregation within hospitals was overturned in the federal courts. Where's the AMA on all this? Well, still in 1963, the AMA, with that legislation overturning segregation within hospitals, was still urging Congress to amend the Hill-Burton Act to allow private hospitals to not have to change their private, quote, private character in any respect, other than outlawing outright racial discrimination. So it would basically, they were still promoting segregation. Anyhow, let's get back. There's a bit of a diversion. Let's get back to Truman and the national health insurance. So strikes have been convulsing the nation. A lot of Americans are back home. Labor unions are trying to find their role in supporting employees. Truman proposes a fair deal, no longer the New Deal. This is a government-funded health insurance via a 3% payroll tax that would pay for medical, hospital, and dental care for the majority, 80% that should be a percentage, not an and sign, of the population. And all eligible persons would be compulsory for them to enroll. You want a large risk pool. You want to do community rating. 60% of Americans at that time were in favor of that proposal. By the way, after the war, the National Health Service was expanded. It had been already existing in pre-war Britain, but it was expanded greatly. And that was actually a true socialized model. In Britain, the government was building the hospitals. They were directly paying the salaries. That was not the case for Truman's proposal. His national health program would actually have the hospitals built privately. The doctors remain private, self-employed clinicians that would be reimbursed, similar to what we see in Medicare today. Its funding was to be similar, though. In most nations, funding for national health programs are via payroll taxes. So again, there's a discrepancy with what's happening here and elsewhere. This may be sounding familiar by now. This is opposed by the AMA, the American Hospital Association, Chamber of Commerce. The other thing that might sound familiar is Red Scare. This labeling of Truman's plan as outright socialism. Now, during this era, remember the atomic bomb had just been dropped on Hiroshima and Nagasaki. You had Russia deploying and doing above ground atomic bomb explosions. Americans were frightened of Stalin, and Red Scare was easy to induce. What they didn't happen to distinguish for the American public was that Truman's plan was not a socialist plan. It was basically a federal coverage to provide care via a private American medical profession. The role of unions during this time was split. They were looking forward to being able to provide health benefits. So those folks who are optimistic and said we're going to be able to regain our ability to provide health as a job benefit through the union were opposed to a national health plan, assuming that responsibility. Some unions supported it. With all those strikes that were happening in 1946, actually a conservative Congress came to pass. And with that came a Taft-Hartley Act. This was a law which limits the power of unions under collective bargaining. Again, Red Scare, unions, oh, they must be pinko. So we're going to try to maintain American capitalism without limit. So initially, the Taft-Hartley Act said that unions can only have so many responsibilities to provide benefits for their employees. However, in 48, the Supreme Court ruled that health benefits were a legitimate issue for union management negotiations. So again, what role, when that was confirmed, unions no longer supported, those that did, no longer supported a national health insurance. They wanted to be the ones to provide that care for their employees. The other issue that was going on around this time was, and this is kind of interesting, there was fear among Southern Democrats that this federal coverage might result in outlawing segregation in hospitals. If you've got, because the federal government was pushing integration and they knew that this would be a federal rather than a state program. So in fact, the Democrats in this mixed Congress did not have the votes to pass a national health insurance, and it did not succeed. Come the roaring 50s, the 50s were an era of a huge expansion in terms of our economy. During this era, Congress basically made employee-sponsored health insurance non-taxable for the worker and maintained the tax benefits for the employer. So basically, employee-sponsored insurance was becoming equivalent to a non-taxed raise in salary for the worker and had lots of perks for the employer. This was, again, just an editorial cartoon where supposedly doctors are having their strings pulled by socialized medicine, again, with part of that Red Scare. So employee-sponsored insurance was growing. By the way, we're going to take a break shortly, but employee-sponsored insurance was growing in the post-war economy. Again, the major employers, AT&T, the auto the big three, they all were in favor of employee-sponsored insurance. About 75% of adults less than age 65 had their health insurance through their work, through their unions, or through an employee-sponsored insurance or Blue Cross Blue Shield. During this era of interest, the Veterans Administration expanded because of the GI Bill and soldiers coming back from the war. The Indian Health Service was formed. And again, people were patting themselves on the back. America was celebrating its affluent society. Again, there's a huge consumerism, refrigerators and dishwashers, and the American dream was being fulfilled. And during this time also, there are other, it wasn't Marcus Welby, which followed, but there are fictional dramas of Dr. Kildare and Ben Casey, these surgeons, who you may have heard of some of those programs that were common to many Americans' experience. Um, this So let's take a diversion again, a patient-employee third-party relationship. What does that look like? So you have an insurer, a third party, that meets with an employer or the employer's or the union that works for that firm, and they negotiate a price for the workers in that particular factory, let's say. They will set the price for a benefit package for those employees. The premium, the cost of that package would be determined by how many workers that industry had in that factory and the general state and health of that pool of workers. Once the employer negotiated the agreement with the insurer, then they would say, okay, this is what I'm going to offer to you guys who are working for me. But they could choose more than one plan. And they could also decide what percentage the employee was responsible for paying for that plan. And as we mentioned, Blue Cross Blue Shield was the largest third party. And again, they had economy of scale with large pools. So that worked for many Americans during the 1950s. As we mentioned, it was not just an affluent society. We've always had huge diversion in income.